Is it recording? Okay. Welcome, everyone. Thank you for attending our third annual Global Perspectives in Nursing Roundtable. This is one of my most invigorating events to be involved with. We bring our colleagues from all around the world to bring an international perspective on an issue that's very common to us as educators and practitioners. It's wonderful to have this collective intelligence and this global collegiality present this morning. So I think this will be such an enjoyable roundtable as we talk about delivering midwifery education and practice. I want to introduce you to the moderator for today. It is Dr. Erica Sanner-Steer, who will be introducing and moderating the panelists. Erica?
Good morning, good afternoon, and good evening. We are delighted that you're here today. I will be introducing each speaker and reading a short bio about them. And I will also be keeping the time to let the speakers know when their time is coming to a close, and they'll see a blue icon come up on my screen. So please make sure that you are looking for that. Each speaker has 8 minutes to present to us today. First up is Yukari Igarashi. She is a professor of women's health and midwifery at St. Luke's International University. Dr. Igarashi earned her PhD in nursing from St. Luke's International University and a master's degree from the University of Sydney. Dr. Igarashi's specialties include transcultural nursing, disaster nursing, women's health and team-based learning. She has conducted extensive research on immigrant reproductive health and the advancement of culturally competent care in Japanese healthcare systems. Dr. Igarashi is also working on disaster preparation in the community with local governments. She made a disaster preparation booklet with the Tokyo Metropolitan Government. Her focus in disaster preparedness and support is on persons requiring special care, such as pregnant women, mothers, and babies. This includes educating these populations on how they need to prepare for disasters, as well as how they can best protect and support themselves during disasters. Dr. Igarashi, take it away.
Thank you for the introduction. This is a great honor to be here and to have the opportunity to discuss this topic with you today. My name is Yukari Igarashi. I'm a midwife and a faculty member at St. Luke's International University in Tokyo, Japan. It's pretty late here in Japan, like 10 p.m. late. So if I trip over my word a bit, it's probably because of the time difference. And I'm sure you can all relate, virtual presentation can be a bit a struggle sometimes. Today, I'll be sharing my experiences in supporting women's health during disasters, and then I will give some ideas for integrating education practice in midwifery. Next slide, please. About disaster in Japan. Earthquakes and flood happen in Japan every single year. Just this past January, an earthquake occurred in the Noto Peninsula, causing a tsunami, fire, and mudslide, resulting in 244 deaths. Today, I will focus on a major past disaster, the largest earthquake to take place in Japan in the 21st century so far. In 2011, a massive earthquake occurred off the Pacific coast with a magnitude of 9.0, resulting in more than 22,200 deaths or missing persons. The yellow area on the coast indicate disaster zones. Huge areas were destroyed at that time. Next, please. I went to the affected region 3 weeks after the earthquake with one NPO and volunteered there for 9 months. I visited several shelters to survey public health status and victim needs. Afterward, I set up a project to support the women there. Next slide, please. Women's health at that time was deeply impacted and had gotten much worse. There are many concerns due to displacement, high stress, very cold temperatures, low hygiene, and higher rate of infection diseases. Next slide, please. Public safety was also a big concern. At that time, men were leaders in most shelters, and women were not involved in shelter management. As a result, women's needs were not sufficiently being met. Next slide, please. According to our survey, women encountered various problems. Maintaining personal hygiene was particularly challenging due to difficulty in self-care. Public safety declined, so women needed to find a way to protect themselves. Next slide, please. From the first 6 months after the disaster hit, we visited each shelter once a week. We typically stayed at the shelter for about 2 hours. During these visits, we provided instructions on how to use feminine hygiene products and discussed safety practices. Additionally, nurses offered private consultation to those in need. Next slide, please. While in the shelters, I also assessed the situation of mothers and babies who were impacted by the disaster. Based on those assessments, I will describe how we need to support persons requiring special care in the shelter. First, pregnant women. For the first trimester, it is advisable to prepare a private space for them due to nausea. For the second and third trimesters, because their belly is getting big, they cannot see steps by themselves, so fall prevention is crucial. Western-style toilet preparation and priority use is also important, especially if squat toilets are more common. We found that pregnant women should not be left alone because their anxiety can be more intense compared to others. Encouraging pregnant women to maintain a comfortable posture can help prevent uterine contraction and swollen feet. Next slide, please. For mother and babies, they require assistance even during normal times. In a shelter, it is essential to provide them with isolate and special space. Their schedule of time is totally different from others, and it's important to accommodate their needs. Mother and baby need to be able to breastfeed when they want to without being seen by the public. Next slide, please. Tell mothers that if they can breastfeed their babies, their bodies will continue to produce breast milk. Encourage them to continue breastfeeding and only offer formula when necessary, even if there is enough formula in the shelter, because mother and baby will lose advantage of breastfeeding if the breastfeeding or slows down or stops. It is also important to provide a private space where a mother and baby can relax and breastfeed comfortably. Next slide, please. To support mothers who feed their babies formula, please refer to the following instruction listed on the slide. Next slide, please. As a midwife and educator, I give lecture to women, university students, and community members to help them understand how to prepare for disaster for survival and recovery. What we discussed today is based on my experiences working with victims of the 2011 earthquake in Japan, as well as my research in disaster nursing. The lessons I learned from the victims have been invaluable, and I believe it's my responsibility to share their experiences and message with all of you. By doing so, you can consider them when supporting community in disaster preparation and recovery effort. While not all midwives can be first responders or specialize in disaster relief, it's still crucial for all midwives to understand how to support those potentially affected by disasters. In addition, the role of first responders is immediate and short-term, whereas the role of midwives in promoting health to those impacted by disasters is long-term as community goes through the various stages of the recovery process, which can take months or even many years, depending on the type and scale of the disaster. They can then educate their communities on how to assist mothers and babies during disasters and how to best prepare for them. Additionally, in the event of the disaster, midwives can potentially provide support to promote the health and hygiene of mother and babies. Next slide, please.
Dr.
Thank you for
Igarashi?
kind attention.
Oh, I'm so sorry. That was your last slide.
Yes.
We're right on time. Perfect, perfect. Right on time. Thank you so much for that presentation. And actually, we would like to go back a couple of slides because Kimberly would like to talk to you about the CEs associated to this event.
Good morning, good afternoon, good evening. We are offering continuing education for our presentation today. The continuing education learning objectives are here for you to read. Next slide. If you are wanting to receive a continuing education, it's really important that your Zoom participant name be shown so that we can give you the credit that you would like. So make sure that you have your full name, your first name, and your last name so that we'll be able to confirm your attendance. We will not be able to award continuing education credit or a certificate of attendance without your first and last name appearing on the Zoom attendance log. Next slide. These are our continuing education credit statements for our Roundtable series. Next slide. All individuals who were involved with the organization planning, selection of speakers, and the speakers have completed conflict of interest disclosures. Next slide. And here are the instructions for obtaining continuing education credit or a certificate of attendance. You'll need to sign in using the code, the 71EMYD. The deadline for doing this will be April 3rd. Use the sign-in code to document your attendance and access the evaluation. Choose one of the following ways to enter the sign-in code and complete the course evaluation. And these instructions will also be added to the chat and also shared after the presentation with our post-presentation information that Alexa will show out. Thank you.
Thank you, Kimberly. Appreciate that. And next we have Dr. Evelyn Rotich. Evelyn is a Kenyan midwife who served at the ICM as the head of midwives team from May to December of 2023. She holds a Doctor of Philosophy from the University of Cape Town, South Africa in 2020, a Master's in Midwifery from the University of Nairobi 2006, and a Bachelor's in Nursing from University of Eastern Africa, Bariton, 1997. Evelyn had wide experience in health leadership, education, regulation, practice, and association. She pioneered the birth of Midwives Association of Kenya, served as a chairperson at the Nursing Council of Kenya, served as a senior lecturer at Moi University, and a county executive committee member in the county governance of Uasin Gishu. She has participated in the development of different policy documents at the Ministry of Health in Kenya. She has published and served as a reviewer in refereed journals and she is an affiliate fellow of the Kansas University and has served as a coordinator in collaborations between Moy University and different institutions globally. Welcome, Dr. Rotich.
Thank you very much. I'm very happy to be here again. This is my second time at the roundtable discussion, and it's always exciting to be part of the presenters. I'll talk about revolutionizing midwifery, adept, and ingenious care for modern challenges. We know that midwives play a big role across the childbirth continuum. Midwives provide care at preconception care, prenatal, labor and delivery, postnatal, and care also after postpartum. Currently, there is a global shortage of 900,000 midwives. And yet we know that midwives provide 87% of essential maternal and newborn care. They also avert 50% of maternal deaths, stillbirths, and neonatal deaths. Midwives also have an impact on over 50 other health-related outcomes, including immunization, malaria, especially in the lower to middle resource countries, HIV, TB, breastfeeding. And there is evidence that when we achieve universal coverage for midwives by 2035, there will be a decrease in maternal deaths by 67%, newborn deaths decrease by 64%, and 65% of stillbirths. If there is a less ambitious increase in the coverage of midwives in the next 5 years by 25%, there could be also averting 41% of maternal deaths, 39% of newborn deaths, and 26% of stillbirths. With only a small increase of 10% over 5 years, midwives still can impact in reduction of maternal deaths at 22%, 23% of newborn deaths, and 14% of stillbirths. This means that midwives are very critical in saving lives of mothers and the newborns. The evolving landscape of midwives dates back to biblical times in the book of Genesis and the Exodus in the Bible. Midwives provided care to women and their newborns. In ancient Greek times, Greek, Roman, even India, China, midwives were respected and they provided care to their community. As the landscape evolved, there came in medicalization or male-dominated physician-led care, and this led to a reduction of the number of midwives and the role of midwives. And also, there are so many challenges that contributed to a decrease in the role of midwives, including increased medicalization, shortage of midwifery workforce, and lack of professional integration and recognition of midwives. However, in the 20th century, please next slide. In the 20th century, there has been revolutionary rising of midwifery practice, and due to the revolutionizing of midwifery practice, there is more promotion of woman-centered care and natural childbirth. Through the revolutionization, midwives are able to perform more duties, and when they are supported, regulated, and educated, they are able to impact on the health outcomes. What has happened in the 20th century, there is now utilization of like health workforce analysis data, and the use of health workforce analysis data has helped in predicting and addressing workforce shortages, in optimizing staffing levels and resource allocation, in improving return on investments, and in aligning training programs with workforce needs, and in supporting strategic decision-making. Another issue that has happened is revolutionizing of midwifery practice by expanding the scope of practice now that they are able to work collaboratively with other healthcare providers, including obstetricians and pediatricians, and provision of referral mechanisms. And through education, there has been use of competency-based education and curriculum. And this requires a look critically into the three main areas of learning resources for midwives, because this is one area that needs to be upgraded at and looked into. The second one is looking at the faculty, developing faculty to ensure that they are able to use current pedagogical methods and use research and evidence-based practices, and also to leverage technology in during teaching. And technology can be used nowadays. There's AI, AI, sorry, it's disappeared the full one, but at least AI can be artificial intelligence, which can be used to view actually, like if there are issues to do with breech delivery or deliveries that are complicated that midwives don't encounter every day, they can utilize AI to get that experience so that when they encounter such complications, they are able to address. In having the power of adept and ingenious midwives, there is improved maternal and newborn health outcomes. There is enhanced access to care, and women are empowered. They have more information. They are able to make decisions regarding their pregnancy and choices during birth and delivery. They are able, also that providing ingenious midwifery care addresses health disparities, where you have at least midwives who are trained to international standards, providing care to every woman, and every woman having access to midwifery care. There is also continuity of care, and once there is continuity of care, you find that midwives understand the woman, and the woman also knows the midwives by name. So there is more collaboration, there is more interaction, and there are better outcomes. And that also leads to valuable patient-centered care, whereby the midwives allow or work with the women and their families in decision-making. They collaborate and use evidence-informed practice. And what is also important in adept and ingenious midwives, they uphold the ethical code of conduct. That is my just short preview about revolutionizing midwifery care. Thank you very much.
Thank you so much, Everlyn, for that presentation. And next, Alexa, do we have the next slide? All right, our next speaker is Dorothy Devakarubai. Dorothy is coming to us from Christian Medical College in India. She's completed her master's degree in maternal nursing and has been working in midwifery for the past 2 decades or so, 2 decades plus, and she's passionate about practicing and teaching midwifery. Welcome, Dorothy.
Thank you, ma'am, and all of you for joining this program. Today, I've been here to talk about culturally sensitive midwifery education. Delivering quality midwifery care to large populations is always challenging. Health-seeking behaviors lead to delay in healing medical help for reasons that have more to do with culture, social practice, and religious beliefs. Respect for cultures and traditions remain a fundamental requirement for midwifery. Evidence suggests that discrimination does not exist during midwifery care. Culturally sensitive healthcare affects when clients' expectations are aligned with healthcare providers' knowledge, attitude, and behavior. It is not the culture that shapes the healthcare of the healthcare experiences of individuals. The process of developing culturally sensitive cultural sensitivity needs to be prevented by a desire within the professionals become culturally sensitive, more than more in a widely diverse population like in India. Thus, cultural sensitivity, sensitive midwifery education can be considered, including various aspects such as cultural competence training, diversity in care practices, language and communication, cultural awareness exercises, community engagement, self-reflection awareness, respect for diversity, continuous learning, feedback and evaluation, policy, and institutional support. So cultural competence training, if we see, offers comprehensive training program covering cultural awareness, sensitivity, and competence. So in the curriculum of midwifery education, this has to be incorporated. And it has been shown that there are courses where cultural sensitivity is being incorporated with topics such as cultural humility, communication skills, and understanding diverse beliefs and practices. So this in turn may help in better care, providing better care for the mother. Then the quality of the intercultural care that is being provided by the midwife will play an important, significant impact it will have on the mother and on the baby. And moving on to the diversity in care practices, emphasize emphasizes the importance of respecting and accommodating diverse cultural practices and beliefs during pregnancy, childbirth, and postpartum care. So, if we see there are lots of diverse practices that are being followed in cultural areas where aspects such as like you wouldn't want to visit a doctor on a particular day, where you would say that um, it's better to have primary person, or you would like to attend only to a female doctor, things like that, and you wouldn't take the baby on, even if the baby is quite sick, things like that are there, and this has to be addressed to where uh, that kind of cultural practices need to be introduced to the midwives early, not when they are working, but it can be introduced into the education system itself to identify. So there can be studies done
Dorothy,
to identify the
I'm going to
right.
interrupt for a minute.
Only
I need, yes, we're having a little trouble with the distinction of your words. So if you could lean in and maybe slow down.
okay. Should I go a bit slow?
Yes, that's way better. Right there is better.
Okay. It's like the diversity in care practices that exist. So if we are able to identify where in medical education you can have research to identify the cultural practices, and then we can incorporate them when we are providing the care to the women who are culturally bound by the practices. Then language and communication. um, in this aspect, training needs to be provided on effective communication with women from different cultural backgrounds, including language interpretation services, and use of culturally appropriate language. Sometimes midwives are unable to interpret the language that is spoken by the mother or the family. So they come from different backgrounds and they come from different cultures. So there are so many different languages that they speak. And they are unable to understand the language spoken by the midwives. And so language interpretation can be used, or the midwives can be introduced to some language classes where they will be able to communicate freely with the mother. Cultural awareness, cultural awareness exercises. This incorporates interactive exercises and case studies that highlight the impact of culture on healthcare decisions and outcomes. So it would be better, like, yes, it is that masterpiece where we will be able to incorporate if there are any cultural traditions that we need to adapt into it, and it can be brought about when we take care of together. The next is community engagement. This fosters partnership with local community leaders and organizations to better understand cultural norms and values and involve them in the development of culturally sensitive care practices. So it could be easy for us to approach the women with the help of the leaders in the community, where we can bring about a lot of change with the help of midwives, and that can be brought into force. And we have good partnership with the leaders in the community, with ministry education itself, rather than with working midwives. Then self-reflection and awareness, where the midwives can be encouraged to reflect on their own cultural bias and assumptions and to continuously strive for self-awareness and improvement. So sometimes we are also culture-bound, where we may be having a lot of assumptions that uh, a particular culture that is being followed by women is not correct, or we maybe be restricting those things what they are following. But then we have to be aware of the cultures that they follow, and we also need to consciously make sure that we do not assume things what they are doing, and we will have to slowly bring about change, and we have to be aware of it. The next is for respect for diversity. So emphasize that women importance of treating all women with dignity, respect, and without discrimination, regardless of their cultural background. So this is very important for midwives. Yeah? We need to educate our young midwives that we need to be careful when we are caring for them, because they come from different cultural backgrounds, and we have to respect their dignity, and we should not be discriminating them in any way. Uh, because we may be thinking that they are of a high background or a low background. This culture not to be particular group, not to be entertained, not to be allowed in a place, not to be kept along with another woman of another culture. Things like that, we have to be really careful when we are caring for them. Continuous learning is another point that we can adopt when where we will promote ongoing
Dorothy?
education and
Dorothy,
yes.
I'm going to call time. We're about a minute over time. So sorry to
I
stop
guess
your
that
presentation,
just
but
the
I
case
know
now. I'll finish now. Is
we
it
will,
okay?
we will have time for questions at the end. So we'll make sure to get to you so that you can present that important content later.
Okay, ma'am. Thank you.
Thank you for that presentation, Dorothy. And Alexa, next up we have Naisha Becerra Chauca. Do we have a slide for her, please? Yeah. Naisha Becerra Chauca is coming to us from Universidad Peruano Cayetano Heredia. She is a midwife with a master's degree in public health and global health, joining us from Lima, Peru. She has dedicated a year of service as a midwife in rural community in the north of Peru. And she has also worked on research projects concerning sexual and reproductive health of women in prisons, obstetric violence, early initiation of breastfeeding, among other topics. For the past 5 years, she has worked in the area of evidence-based health policy decision-making. And welcome, Naisha.
Welcome, everybody. Thank you for having me. I'm going to start this presentation with some questions to the audience. So have you ever questioned that, is there scientific evidence that supports your current practices or the new intervention that you would like to implement? Is that evidence of high quality? Can we trust that evidence? Some might confidently say yes. Others might say, I'm not sure, and some others might not respond simply. But I am starting with these questions because these questions initiated a process in our brains is an example of critical thinking towards evidence-based practice. let me share with you a short story about me. I was doing my internship in Peru in a public hospital, and I saw the regular use of manual fundal pressure in the second stage labor. So I asked myself, what is the evidence behind this practice? I found systematic reviews, clinical practice guidelines that presented that actually it was not effective. And I asked myself again, what do they still do it? Since it has not been demonstrated that it's effective and it is very painful. Among a lot of factors, there's not like a specific explanation for why they're doing it, but one of them is that maybe these people are not asking these questions that I have asked you at the beginning. So what is critical thinking? This is definitely a complex process. Different authors have different meanings, but all agree that it's a combination of skills that include information seeking, evaluating, analyzing, and synthesizing. It involves formulating questions in order to gain a deeper understanding of what is happening and why it's happening. It also needs to differentiate between opinions and facts and the evidence. A recent review has highlighted some attitudes for critical thinking, such as having self-confidence, having a broad perspective to analyzing situations, creativity, flexibility, the ability to make decisions in uncertainty, inquisitiveness, humility, independent thinking, intuition, impartiality, perseverance, and logical reasoning and reflection. I will show you how all of this is embedded in evidence-based midwifery. Evidence-based midwifery is a process that links the scientific information available with implementation of the best practices and policies. To start this process, we all obviously need to have scientific information available. However, it is true that not all of us are going to become researchers, are going to generate information. But it is imperative that all of us develop the skills to analyze that evidence, to have a deep understanding of what is the strengths of the evidence and its limitations. So most commonly known, evidence-based midwifery, everybody knows this better, I think, by evidence-based practice. It has 5 steps. Ask questions, acquire the information, apprise, apply it, and assess. All of this process, we need to have critical thinking skills at every stage. For example, for the first step, we need to be curious about what's behind certain interventions. Is there evidence around it? What kind of evidence? What are they measuring? We need to think critically about our information needs and formulate these questions. After formulating these questions, there are several kinds of questions. We need to search information, but where do we do it? Are all databases the same? Are all the evidence I need in those databases? Do I need this information for clinical practice or for public policy decision maybe? So this is different. We need to have this in mind. We need to be inquisitive about the intentions of our search and differentiate the opinions and the facts. Also, let's say we found the information, but we need to evaluate it. We need to apprise the evidence. We do have several tools to do it, but this is not a cookbook kind of process. This is not a recipe. We need to deeply understand what was measured, how it was measured. Was it done through a valid process? Does it help me to answer my questions? To what extent? So for this, we need logical reasoning, we need independent thinking, impartiality also, and self-reflection. The next step is really critical because we need to apply this information. We need to make decisions. However, it is not that simple because to make a decision, the evidence is not enough. We need to take into account other factors like patients' values and preferences, the context. It's not the same to use the information that was generated maybe in Europe to a population in the rural part of Colombia, for example. It's different. We need to ask ourselves, is that culturally adequate, as Dorothy has just mentioned? And if you are in a health policy arena, you will need to ask also about the impact on equity and maybe in the economy. So there's other factors that you need to take into account. So you have to have a broad perspective, self-confidence, and the ability to make decisions in uncertainty, because let's face it, there's no evidence for all of the questions that we have, but we do need to make decisions, even though we are uncertain. Last but not least, we need to assess. After implementing our decisions, we need to be humble enough and ask ourselves, did it work as I intended to do? If not, why not? We need to have self-reflection, persevere, and keep gathering information. But with this, I was trying to show you that evidence-based midwifery is not a straightforward process. We need to develop and practice critical thinking skills and attitudes to complete every step of this process. Promoting critical thinking skills is crucial in midwifery education to foster a reflective and critical approach to our current practices, both at clinical and also at a policy level. All of us can contribute to cultivating a critical thinking environment in our workplaces and also in the classrooms. To sum up, I think critical thinking is the constant of evidence-based midwifery is essential for evaluating evidence and making informed decisions. Developing a culture of critical thinking is a collective responsibility that contributes not only to the advancement of midwifery, but also to the empowerment of midwives. Thank you very much.
Thank you, Naisha, for that wonderful presentation. And next and last, we have Dr. Christy Evers. She is an accomplished healthcare professional specializing in nurse midwifery, nurse education, and clinical leadership. With a Doctor of Nursing practice from the University of Kansas Medical Center, where she works now. She possesses extensive experience in prenatal care, labor and delivery, and postpartum support. Currently serving as a clinical assistant professor at the University of Kansas School of Nursing, Christy excels in facilitating graduate nursing programs, collaborating on curriculum development, and engaging in clinical practice. She holds leadership roles in professional organizations such as Sigma Theta Tau International and the American College of Nurse Midwives, showcasing her dedication to advancing the field. Christy's commitment to excellence in nursing education and clinical practice is evident in her impactful contributions to the healthcare community. Welcome, Christy.
So to start with a little background, a couple of years ago, the KU Midwifery program added a class to our curriculum to focus on a few key pieces of midwifery education that had been previously placed in other courses, but we wanted to draw these pieces together into one course. It is one of the first specialty didactic courses our midwifery students take. This course is called Nurse Midwifery Professionalism Seminar. Well, as we were developing this course, Dr. Krista Ramirez-Henry, another midwifery faculty, and I were in the Duke Advanced Practice Providers Leadership Institute Fellowship. Our course became the subject of our project. Our group was composed of Dr. Ramirez-Henry, Nellie Medeiros, she is with our Teaching and Learning Technologies at KU, and I. One of the course objectives is to explain the history of midwifery globally. For us, this also meant to look at the global impact of midwifery. Well, Nellie connected us with Dr. Michelle Cochran, who teaches a Global Perspectives in Nursing course within the School of Nursing and has been working with many international collaborations already. Dr. Cochran was able to initiate this collaboration with Dr. Rodich and her team at Moi University in Kenya. We found this collaboration worked well with the Moi class titled Advanced Midwifery 1, Preconception and Antenatal Care. Dr. Cochran also helped us apply for the COIL grant, which is the Collaborative Online International Learning that allowed us to facilitate this collaboration. We met with the faculty of Moi University before the course and worked together to develop assignments that the students could do together using the objectives from the courses of both schools. We had several groups that were formed with the students from both schools. These assignments were then turned into group presentations and were given in a Zoom call format. We met on Zoom several times throughout the semester, both as faculty and students, and also just as faculty. The students worked during off classroom time. Sometimes they worked synchronously and sometimes with Zoom calls, and sometimes asynchronously via emails. The students had their own university emails. Moy University used theirs and KU used theirs. The students delved into current and past key components of midwifery. They used resources from around the globe to learn more. They focused on the key differences and similarities of midwifery from both countries. These assignments included answering questions such as describe the role and qualities of the nurse midwife as a leader within the profession, analyzing management theory and philosophy guiding clinical specialization and practice. We also had the students discuss principles of management in hospitals, nursing and midwifery education programs, and community healthcare units at all levels. They discussed entrepreneurship in midwifery. We had the students compare and contrast the roles and competencies of advanced practice nurses and midwives with each other and with those of other healthcare providers, including technical and professional nurses and midwives. And finally, they discussed the roles and position of advanced nurse midwifery practitioners and professional nurse midwives. These students really enjoyed this collaboration because they found that geographically there were many similarities and, as expected, some differences. The students were in awe of the similarities they discovered, and it strengthened their resolve to be midwives. A student was quoted as saying that midwifery is universal. The challenges facing midwifery as similar despite being different in different cultural settings. Another said they weren't sure what to expect when they began this collaboration, but they are very grateful to have done it. They were able to learn that most nations across the world are having very similar struggles to ours, particularly in relation to obstetric care. It made me and my profession feel seen and more important than ever to complete and practice. These students learned that the factors that they are facing in taking care of women are global, that they are not regional, and that they are so important to strengthen the profession of midwifery, and that they have a voice in global care of patients and women, or their women. We received such great feedback from this collaboration, such as we discovered there were a lot more similarities in the midwifery practice in between our countries than differences. And this class is making me more aware of the global impact of our role and its rising legitimacy. It makes me want to establish an international presence as I get more established as a practitioner. This slide that I'm showing you is the poster presentation our group prepared, and our group is everybody that participated in this collaboration, from the faculty to staff and every other background person that I was presenting at the Sigma Theta Tau Biennial Convention this past November about our collaboration. My biggest takeaway is that everyone has strengths, and using them helped this collaboration and it enhanced the experience for all. Finding your team's strengths and bridging out to meeting and connecting with new people can only make the experience better and thereby make the impact that much greater. We are thankful to all involved, including our Kenyan partners, OIP, Nellie Medeiros, and Dr. Michelle Cochran for their assistance with this amazing collaboration experience we had. Thank you.
Well, that concludes our presentations from our presenters, and what a great wealth of information. What we'll move on to now is Dr. Erica Samuel-Steer and myself will present some questions that were presented to us to each presenter, and then we'll open it up to those in the audience. We'll take questions from your chat, or you can raise your hand and present your question live. I will also add that at the end of this presentation, we will be asking you to put in the chat, what is the first thing you will be telling someone about after you leave this roundtable? A main takeaway or something that you will share immediately, and be thinking about that during this time, and we'll have you type that into the chat when you're ready, or we'll be prompting you to put that in at the end of this session. So I'm going to first present my first question to Dr. Agasari when you were talking about midwifery in disaster areas. I'm curious as to what degree should all the midwives be involved in disaster preparation and support, and how could that be reflected in the education of midwives?
Thank you for the question. When disaster initially strike, disaster medical assistant team, DMAT, and first responder are typically the first to arrive in affected area and provide support. A few weeks after the disaster, healthcare professionals, including midwives and nurses, have an important role to play in not only treating the injured and ill, but also in providing preventive care, promoting awareness and hygiene, educating victims, and managing shelters. For this reason, all nurses and midwives should strive to have a basic understanding of how to support victims in disaster area. This should be incorporated into midwifery curriculum. In addition, especially in the absence of disaster, midwives play an important role in educating individual and community on how to prepare for disaster, as well as how to support pregnant women, mothers, and baby during disaster. So disaster preparation looks different from place to place. It's key to note that disaster aren't always massive. Disaster could also look like a power outage in the middle of the winter storm or extreme temperature. It's important to know what disaster could affect locally in order to prepare based on available resources and educate the community on how to prepare accordingly.
Thank you for that answer, Dr. Igarashi. I would like to ask a question to Evelyn. Can you share your thoughts on potential ethical considerations of certain innovations in midwifery? You're muted, Evelyn. Can you unmute yourself? It looks like you're unmuted now. Do you want to try to speak?
You know, there are some of the considerations that usually that as midwives probably we have taken for granted. You realize that when providing care, it's like it's automatic, you're going to provide care without asking the woman for informed consent or autonomy. Because sometimes, what if you had during my presentation, I talked about decision-making and patient-centered care. So there's need really to respect women's rights to make informed decisions about their care. And the need to have informed consent, the need for confidentiality and privacy. You'd find that in our settings, sometimes you would be providing care or handing over a report about a woman. And when you are handing over, there are very many students, or the neighboring woman would be listening to the condition of the woman. And also providing culturally sensitive care, which is very important. Sometimes we provide care without considering the cultural implications that it could have to our clients, and ensuring equitable access to care, which is very important. And also professional development is very key. When it's very ethical, it's very unethical when we are providing outdated care. There's so much evolvement and there's so much evidence-based practice that has, and there's so much research that has been generated. And yet you would find that in our practice, we still provide care, which sometimes is probably not evidence-based and is not informed by decisions. You see, one thing that I would talk about, like this medicalization of birth. We are used to augmenting labor. We don't even ask. There's evidence that now we allow pregnancy to follow the natural physiological way and minimize use of interventions. But you find that that is still a practice that is happening in some of the settings that we are in.
Thank you, Dr. Rotish. I get very enthusiastic when I hear each of you speak, because I think all of those concepts can be applied to all of our practices. It's very invigorating to hear each of you speaking, and I can apply, even though I'm not particularly a midwife, I can apply everything that you're saying to different practices that we have. I will be directing my next question to Dr. Diva Karubai, and it is about the culturally sensitive education that you spoke about. What are some of the ways of bringing about a culturally sensitive midwifery education?
That's actually what I was sharing now. It's very important for us to identify where there are different cultural groups, and the sensitivity needs to be brought in education, where each one of the midwives will be able to identify what are the different cultures and how to deal with it. So we can actually incorporate in our thing where we have systems where we go to the homes, and we are able to know the cultures when we are there right at their doorstep. So we have here, we introduce our graduates to the program called as the Community Orientation Program, where they go there to the homes of these people, and they may be living not in groups of the similar culture, but they may be living in groups where they are all combined. So they may be living together, but they may be practicing different cultures. So the graduates are able to identify these cultures. The only thing is that we need to introduce curriculum in such a way that we incorporate these cultural differences into our education, where we would be able to cooperate with them, or we will be able to identify that some of these practices may be harmful, and some of them may not be very harmful. So we need to have some bias against our women who come to us to the hospital, so that in that way we'll be able to the midwives will be able to continue their care to the best. So if we incorporate these cultural practices what with that if we learn earlier. Otherwise, it will be, a very the may be quite happy, but actually, or sometimes we also have our own bias. We may be thinking that some of these cultural people are like that, or we may would, unconsciously show the differences.
Thank you, Dorothy. I think the next question goes to Nisha. What challenges have you identified in embedding critical thinking and evidence-based practice into midwifery education?
Well, based on my own experience, I would say that sometimes the process of the courses sometimes are just linked to or the aim of the course of the program. Sometimes it's just to gain the knowledge, but not to question it or like to reflect on the current practices. You know, we usually try to follow like a guideline, and we at least here in Peru we do have some national guidelines, but yeah, unfortunately they need to be updated, and sometimes we just guide the program of the course around this. So I think we need to implement some type of courses or programs, or maybe this kind of collaborations in terms to promote self-reflections in the students, and also in teachers, because in the professors, because evidence is evolving, the science is evolving. So what maybe we were thinking like 5 years ago, we need to update that information and also change our practices. So this needs to be an evolving and very dynamic process. And in the education, we need to let students ask questions. We need to let students to question about what they are doing. If they say, oh, I don't believe this, okay, just look the evidence and bring them to the table, and we discuss it. So I think we need to do it more. We need to also like promote, develop some self-confidence in the students in order for them to just say, okay, I don't agree with this, we need to change it. Or maybe, I have a new idea, let's do it. I think we also need to do this. Maybe it's not like it's straightforward to think when you're thinking about research or evidence, to think about all of these other skills like self-confidence, talking in public, but it is important, because if you do not have this, all of your ideas maybe, or your doubts stays in yourself, and it's not expressed, and are not resolved. And I think we need to, besides just teaching how to research, just teaching how to do like to take care of a patient, take care of women, we also need to let them know that it's okay to ask questions, more, And also maybe I would really add that we need to change a little bit the exams, not exams just to say, okay, this is good and this is wrong, correct answer, but also to questions of reflective things, how do you think about this? What do you think about this? Have you found any new information about this? Because as I always also was listening, I was listening about artificial intelligence and all of these other tools and sources. So this is evolving, and maybe I think we need to change the perspective in education, that it's not the educator that is like giving information and knowledge to the students, but it's like a reciprocal process that we are also learning from the students.
And thank you for that answer. That really goes along with one of the comments in the chat that Kara has put in there, and also with my own experience working with students in evidence-based practice, they find that that a lot of things are provider driven, and they start wondering why. and asking those questions. So that's very insightful answer. We'd like to also invite the chat, everyone in the audience, to put a comment or a question that you'd like to ask the panelists in the chat as we move along with the Q&A session here. Michelle, would you like to take the next?
Yes. I'm going to pose my question to Dr. Evers. And how do you feel virtual collaboration can complement the traditional place-based learning experience for midwifery students?
I think that, first of all, we learned in 2020 how to navigate the online meeting environment. We learned so much during the last 4 years about the importance of being able to meet with others and have ideas with others and not be in the same place. And I think that allows many that do not have the means to travel to experience and become immersed in some ways to other areas and cultures. And I think that the virtual and collaborative learning environment can just get better, because even though we can learn so much by being side by side with others, this complementary area of our students getting to meet with the Moy University students and learn so much about globally how midwifery is impacted. It really speaks to what else Naisha was saying, that students are able to question and learn from others. And so that's something that some students wouldn't have the opportunity to do. And they are able to question the whys and learn how other areas are doing things. And that's really how we create globally midwifery making an impact on these women.
And I can add to that. I had a midwifery student in another class that had been through your COIL experience with Moy University. And she brought up the fact that she was introduced to a midwife in Kenya, that she felt like she was a colleague afterwards, that they would continue to connect with each other. And I love that it was a semester later, it was a policy class, and she was talking about policy and midwifery. So there's implications of just the introduction that is, nothing can replace place-based, but I can attest to the fact that those students still talk about that experience a semester or two later in other courses and apply it. So it was impactful. I think we can now look at the chat or about questions to the audience.
It looks like Mary Rodriguez has a question.
Yeah, I would just like to ask our international panel, what you think is the most critical for the promotion of midwifery care or the midwifery profession globally? Like what is the most important thing that you think will help us like rightly take our place as midwives?
I don't know. I can go in and respond a little bit on that. What is important, first of all, is ensuring that midwives are educated and trained to international levels, ensuring that there is accreditation of midwifery education programs using competency-based, whereby they're using different pedagogical methods like problem-based learning, issues of case studies. We also need to strengthen regulatory frameworks in our different countries. Once we have strengthened regulatory frameworks, it means that as in nursing, the way a nurse can practice in any part of the world, that can also happen with midwives. And it's also important to really invest in infrastructure and resources. It's very important to do that, and also to have midwives' voices heard. Most of the time, midwives are not on the table, so it's very important to have leadership, midwife leadership, who are able to articulate their issues on the table and be able to align their goals with the broader health care goals. Like now in Kenya, our president is currently advocating for universal health coverage and also primary health care. So those are the areas that we really need to bring in and see how midwives can contribute to those global agendas, like even the Sustainable Development Goals of reducing maternal mortality. There's also need to engage the public and work with the women association, women rights associations, and other organizations, so that there is really the demand, so that there is demand for the midwifery services. And also when we have our well-organized infrastructure and resources, when the women seek or demand for the services, they get the supply and they get very good care. You know, in one of the things that we were talking about, ethics, beneficence, how can women benefit from the healthcare? There have been issues on respectful maternity care. Those are things that should not be heard of. Instead, midwives should be innovating on better ways of providing compassionate care and be able to actually ensure that there is demand for midwifery services. And I can't forget issues of research and use of evidence and data-led decision making. Usually, when we provide, midwives do a lot of work in the health facilities, but sometimes you find that that data is not even recorded. What they do is not recorded. Another thing is collaborating with other healthcare providers and ensuring that midwives are felt and they are recognized, and increasing their scope of practice, I think, and also advocating for policies that recognize midwives, ensuring that they are paid well, because sometimes you find that in some of the countries, the midwives are not really paid very well. And finally, in service delivery, ensure that they are providing quality service. Thank you very much.
Evelyn, I feel like I could listen to you all day. I just love it. And I know I've mentioned to all of you as being part of the organizational group that, that this is a topic very dear to my heart, having birthed 6 children myself and naturally. And I think midwifery is just such an amazing profession. I do have a question for each of you relative to your context and situation, because to me, this kind of goes hand in hand. And I know Yukari touched on it a little bit. Breastfeeding, I think, is so important for both the mom and the baby, long-term health. And I was just curious from each of your context, how breastfeeding in general is supported, you know, either by you as midwives, but also maybe by policy and government. You know, what type of programs are there? What type of, you know, even marketing, you know, like what is put out there to encourage mothers to breastfeed? And that's for all of you. So whoever wants to jump in.
Okay, I wanted to jump in because I actually just finished my thesis about breastfeeding. So I wanted to maybe share what I found. Well, in terms of the policy here in Peru, we do have like 3 months after birth that the women can take, but they can do it like before labor and after labor, but they usually just work till the labor point to gather all the 3 months. We also do have these rooms, or well, we try to, there's a policy that encourage businesses, you know, to have this room exclusively for breastfeeding. But actually the thing is not the policy thing. I think in Peru, it's the implementation of the policy. Not all of the businesses do it, but we are working on it. In terms of actually what I am breastfeeding initiation. For example, this is something that it is now being more promoted than before, than a couple of years before. For example, when I was a student, this is something that we were not thinking that much, because the general practice was that the baby was born and the nurses, neonatology just take the baby away and that's it. And this was just a couple of years ago. So I think we're changing that. And I just wanted to make to show you what I learned when I was doing this research. I was just comparing the percentage of breastfeeding initiation in primary healthcare, I mean, in facilities that is in the primary level, in comparison with facilities in the secondary and tertiary level, because the secondary and tertiary level are more, their aim is to treat diseases, but in the first level, in the primary level, we are more of the promoting, prevent. So the focus is different, the quantity of resources is different, the quantity also of people going through those facilities is different. So there's a difference within those facilities. And actually, even though we do have some problems in the primary health, the primary level, I found that the breastfeeding initiation, the percentage of breastfeeding initiation was higher in the primary level, because there were less people going there. And so the ratio midwife women, it was better. So there was like one midwife for one patient. Instead of a hospital, we have one midwife for 10 patients or 10 women. So for these reasons, I think privacy to connection between midwife and women, all these factors helped for having a higher percentage of breastfeeding initiation in this particular facility. So yes, that's what I wanted to share with you about what is going on here in Peru, and also about the policies that we have.
Maybe I can go next and talk about Kenya, what has happened in Kenya. What has it's promoted during actually pregnancy. When the woman is pregnant, that is where the breastfeeding counseling and training is started. At least the women are educated on how to breastfeed and the importance, and they are given information on importance of breastfeeding. And usually after birth, the woman is, there is usually encouragement for initiation of breastfeeding within the first hour of birth. Also, the Ministry of Health and other government agencies collaborate with non-governmental organizations in doing advocacy and sensitizing the communities on the importance of breastfeeding. It is also taken in the Health Act, and in there's another act. There are two acts that I know. There is the Health Act, and there is in the Employment Act, where mothers are given like 3 months to breastfeed. So they are given time to maternity leave so that they can be able to breastfeed their newborns. They are also given time when they report back to work. They are given offs or breastfeeding times. They leave work earlier at 3 p.m. so that they can go home and breastfeed. And also there are there has been promotion of baby-friendly health workplaces, whereby you have breastfeeding corners in some institutions. Like I know Safaricom and a few other institutions have implemented that, whereby there's the government policy that you provide a space where breastfeeding mothers can breastfeed their babies. They can take a break and go and breastfeed. And finally, there's one more action that has been done by the government. I think it was done earlier in the 2010, that around probably 15 years ago or 12 years ago, there was discouragement of advertisement of breast milk substitutes. So that is what the government of Kenya has done so far. Thank you very much.
I wonder, Dr.
I would like to
Oh, sorry, go ahead, Dorothy. Go ahead.
I would like to share what happens in India. Uh, as in other countries, what was shared from Peru and Ecuador. I found here also in India, we have a leave that is given for women who are working for up to 6 months. In some places, it's also considered even for a year or two, where they could apply it at different points, but continuous leave can be taken. Um, in some places, with pay or half pay is given as they work. And breastfeeding has not been a problem for Indian women, but still they were much carried away by the substitutes that were available earlier. But now it's been, as it is told, advertisements or use of these substitutes are not permitted. And breast milk bans have also been come up, it's starting to come up now. As it is mentioned by other countries also, here we have places where the women can have a place to breastfeed the baby anywhere. I even have found it in airports or railway stations, in malls, and even in hospitals. We have for our nurses and other people also, we have crush where we can keep the baby, and between times we can go feed the baby and come. So that's been a practice over here. And it's breastfeeding is very common in our rural areas, unlike in urban. But urban, we have these provisions now, and we find that it's being improved.
I'd like to share about a Japanese situation. We encourage breastfeeding, and after delivery, mother stay in hospital for 5 days after delivery, and midwife teach breastfeeding every day. We also have outpatient for the breastfeeding. So 2 weeks after delivery, mother come back to the hospital to check about breastfeeding, and then we can check how to we can teach how to do breastfeeding to the mother and the babies. And also big thing happened 2019. We didn't have liquid formula in Japan, but 2019 liquid formula started to sell in Japan, but still we encouraged breastfeeding mothers. Thank you.
Okay, I'm wondering,
Michelle, excuse me, I just wanted to add something that just came to my mind because I was reading the chat and I realized that some of the participants are sharing the policies in their country. And I think this is excellent example of what is global education, critical thinking, because if, for example, you're saying in this country we have 6 months, in this country we have 3 months of leave. So people seeing this are going to question their policy. I'm going to say, okay, what can we do better? You know, having the examples of other countries. So I just wanted to like visualize this example because I think it's great. And thank you also for the organizer, because that's what we need to start questioning, to start developing ideas to deliver better policies and practices.
I can agree with that. As you were speaking, I was thinking we should have a table up that just compares, because I could see some similarities, but the others were very different. And I think we heard from everybody but US, and I think Kara put some things in, but I didn't know, Christy, if you had a final conclusion of anything that pulled together our perspective that was maybe different in the United States. I could identify with everyone's statement about where formula was preferred at one time over breastfeeding, about the breastfeeding rooms, but I'm not really sure if there's where we would want to go in the United States with breastfeeding, or what is our current state. Do you have any comments on that before we close out?
I think we need to continue to make it a priority, and not just as obstetric providers, but as neonatal providers as well. They need to be on board with it as well and not come up with excuses to not breastfeed. I think we're doing a good job. I think we need to keep that momentum going forward, though.
Well, I hate to end this, but it is 9:27. So I want to thank very much all of our presenters and those of you that have also attended. It is it's very helpful to have people attending from around the world, as you can see in the chat, where there's many that have signed on. I know our latest our people that are attending were well close to a little bit under midnight. So what a wonderful commitment to global education. And I do want to ask everyone for this final few minutes to please type in the chat what your takeaway is that you will be telling someone about today about this roundtable. What is one of the first things you will say and share about your attendance today? So if you could just take a few minutes to type that into your chat as I go on to thank number one, my thank yous for the Office of International Programs here at the University of Kansas Medical Center. That is the hub for connecting us to our global community. All of those presenters today, we have met through relationships we have had built through OIP with the universities and different stakeholders around the globe. So I very, very appreciate the efforts they do and how we benefit from that, and as well as supporting this roundtable. And also thank you to our presenters and to the planning committee that helps. We start this several months in advance, and it is satisfying and it seems effortless because it's fun, but I know that there is a time and effort commitment. So thank you to the planning committee as well. I do think I have a map that shows everyone in the meeting as you put in your place where you are located from. So I'm just going to show that so everyone knows where we have connected today. I put it into the chat. So I want everyone to know the global community that opens our eyes up to where we can see our practice through a global lens. And this helps me broaden my views. So when I'm practicing locally or I'm teaching students, I do have a global lens, which elevates our care and also elevates our practice. So thanks again. And I want to make sure with the planning committee or any speakers, are there any final comments that I may have missed?
Michelle, I think the map is not in the chat. Is there any way to reattach it again?
Let's see here.
It's okay.
There.
Oh, perfect.
Thank you to Kelly for doing that.
And lots of great comments in the chat, what people are taking away. So if you want to spend a minute to read that before we close down.
And if there are, we can never have enough time with our very intelligent, competent partners. So if there's something that you feel needs to be followed up on, there is a follow-up question. Is that correct? Questionnaire that goes out to you all. You're welcome to present that in that follow-up questionnaire, and we can perhaps send it to the appropriate partner or follow up on any questions that were perhaps unanswered. Okay, well, it is 9:30. And it's sad to say goodbye, but I believe we are at the end of this third annual roundtable. So please keep in touch with us. We have your contact information. We will be inviting you to next year's roundtable. And we look forward to your comments. So if there's no other comments from our presenters or our planning committee, I will have to sign off today. And I hope you all have a very good day.
Bye-bye.
Right. Thank you.
Bye.
Thank you.
Thank you.